Okay, hi everyone. Thanks for joining us. We have 60 attendees right now and it's climbing, but as promised, we'll start a couple minutes past the hour because we have a very tight agenda and I want to make sure Nicole has all the time she needs. So my name is Chad McLeod. I'm the Director of Product and Communication at HealthInfoNet. I'm joined by Nicole Yo Fisher. She's our Manager of Clinical Education and the facilitator of our Social Health Data Action Plan convening series. So we are super excited to finally kick this convening off after months of talking about it and planning it and communicating about it. This is really important work. How can we address social determinants of health and sexual orientation and gender identity information with information sharing and information use cases with the Health Information Exchange? So Nicole's going to talk about why are we doing this, what's HealthInfoNet's role in trying to facilitate this data exchange, and what are we trying to do as a result of it. And this is just one of several meetings as part of our convening series, which we'll also forecast a little bit later on and hopefully trigger you all to maybe register for them if you haven't already. So without further ado, I'm going to pass it to Nicole, but I will just say that if you have questions along the way, throw them in the chat, and I will be the record keeper and ask Nicole to answer them as we go. Otherwise, you all are muted to keep the noise down. And so if there are any questions, again, use the chat, and we look forward to talking with you all as the months go on and our convening continues. So Nicole, over to you.
Great. Thanks, Chad. Thank you to Chad. Thanks to Liz Klausner and Lainey Patterson, who are part of the HealthInfoNet team, for working together with me and with all of the wonderful folks and presenters that we have as part of this convening. Like Chad said, we're very excited and anxiously have been waiting to kick this off. And so today is our kickoff call here. Where we're going to talk about the overview of our social health data action plan. This convening series is possible in part for funding received from Maine Health Access Foundation. So without further ado, here, just to sort of lay the groundwork, lay a little bit of foundation, talk about who we are here at HealthInfoNet. And the purpose of this convening. So we here at HealthInfoNet, or some folks refer to us as HIN, we are the state's designated Health Information Exchange, or HIE. Our mission here is to support our healthcare community in creating lasting improvements and the value and quality of patient care and population health for the state of Maine. We provide a suite of health information services to our participants, from data integration through data transmission services. Our connections, so we have multiple connections throughout the state. I feel that we are very lucky here in the state of Maine that we have this wealth of information and data that we've been collecting now for 11 plus years at HealthInfoNet. And so we have more than 870 healthcare locations that we're connected to throughout the state. We have all of the healthcare systems, including acute care hospitals and critical access hospitals. We have over 85% of our ambulatory facilities and all of the federally qualified healthcare centers that are connected to us. We have some different reference labs. We get medication information from SureScripts, a pharmacy claims database. We get pharmacy claims from Maine Care as well. We do have some behavioral health information in the exchange. So I do also consider ourselves lucky that we have both general medical information, but we also have some mental health data that's available. We are connected to the post-acute care facilities throughout the state, long-term care as well. We have the state's Department of Corrections connected to us. We are a part of the state's PMP program, and we also get immunization data from Impact. Also we get Maine EMS reports, run reports that are available for our users in what we refer to as the clinical portal, but it's basically the patient care record. So on top of that, some very exciting news and things that we launched last year at HealthInfoNet was our connection to the eHealth Exchange. As a trainer of our tools and services, a lot of times I would go to trainings and folks would ask, is it just Maine data that you have? And for a really long time, all I could say was yes. But now with this connection to the eHealth Exchange, that's really going to broaden our capabilities of being able to pull in national data, which is very exciting. Currently, we have this connection enabled through the VA, Department of Defense, and the US Coast Guard. So for those folks in the state that are working with our veterans, this has been a huge connection to be able to get VA data, because it can be a rather tedious process otherwise and lengthy. And so for our users to be able to log in and to get that query from the VA is huge. And so that's our initial connection to the eHealth Exchange, with more to come on that. So being able to look at other folks in New England, as well as some other areas where we know folks might be traveling to snowbirds, going warmer places during the winter, and coming back maybe in the summertime to Maine, being able to access that for folks. Different types of data sources that we have. So this is just a really good picture of the types of information that you can access on patients in our clinical portal in the exchange. Demographic information is huge. I always emphasize this in my trainings as well. Because the data that we're getting is nearly real-time data. It's about 98% real-time data. For those folks that's address is changing or their phone number is changing, it can be really helpful to be able to find individuals just by logging in and getting what we have for information. But allergies, medications, lots of different types of documents, encounters, vitals, and immunization information as well. So in looking at the traditional care model, when we think about how folks are getting their healthcare services, primarily what we've sort of seen is now this paradigm shift, where a lot of it was really primarily serving our medical-based community as they were treating folks. Typically, when I think about that, you sort of think of primary care services. You think about going to your regular, PCP, and getting care. You're thinking about it sort of from an office perspective. You go to an office, you're seen in an office. And so that really, to me, is the foundation of what that sort of medical-based healthcare looks like. There, you're getting treated sometimes for chronic conditions. You're looking at your risk for developing chronic conditions, which ultimately is informing different clinical decision-making and care plans along the way based upon what your provider feels that you might need. Very little incorporation of social health data is happening, as well as thinking about any social factors, population-based stakeholders that are a part of that. Treatment doesn't often maybe come into play, or didn't for a really long time. But sort of as you can see in this really neat graphic, I think it really helps to sort of encompass a lot of those different layers, and even really to what we've seen at HealthInfoNet as we've grown, and the different types of data that now we are able to collect, as well as the different types of use cases. It's only going to continue to grow, but even just in the short time that HealthInfoNet has been around, we've really seen a lot of these different components as we think about behavioral health care now, as we think about long-term care and specialty care, as well as incorporating some of the state agencies. When we think about the pandemic and the work that the folks at the CDC have done, we're really looking at broadening this traditional care model. So looking at that broader perspective, so as I just mentioned, having an increase of awareness of how these non-medical factors really impact healthcare outcomes. When you look at the different socioeconomic factors that make up 40% of that little body image there, thinking about environmental factors, thinking about other healthcare factors, and then access to quality care is also really important. So, as we've seen, this obviously impacts, dollar amounts and money and how much, healthcare costs are driven by some of this work as well. So we've seen this, like I've said, here at HealthInfoNet. So we know that if we're seeing this, we know our participants and partners throughout the state are also seeing this broader perspective need. And so what we're really trying to do is a way to improve health equity within the current parameters that we have. So being the state's HIE, we have different guidelines and things to sort of think about and the different types of relationships that we have as well. One of the key things that we've had to consider here at HealthInfoNet is that our participants, that whether they're data sharing participants or we do have what we call view-only participants, so those folks that are unable to share data but want to be able to view the information that we have in the exchange. All of those folks complete a participant agreement, which means that they are HIPAA-covered entities. And so with that, we kind of have to think about what prevents us from being able to connect users to the exchange if they're not HIPAA-covered entities. But we also want to be able to improve, health equity with the measure of our mission. So sort of thinking outside that lens, we have to start with a clinical setting in order to collect this data, but we also really want to work with these community-based organizations and partners to determine what is the very best and most appropriate use of this data to affect change. So some of this work we have been doing in various capacities. We did work with those folks in South Portland and the Maine Council on Aging, doing a municipal data across sectors for healthy aging. And so that was something that was really exciting way to use data and work with Age-Friendly Portland, South Portland on that as well. We've been working with the state of Maine in particular, being able to get DSNP information. And so DSNP means dual eligible special needs plans for long-term care data requirements. So being able to connect all of the long-term care and post-acute care facilities so that we're able to share data so folks know when individuals have been admitted to those facilities or discharged from those facilities. As well as some initial social health data action plan work that we did with Maine Primary Care Association with the federally qualified healthcare centers. So for some of those folks, you might be aware of that work that we did now, gosh, 2 or 3 years ago. My brain gets a little fuzzy during those pandemic times. But we had started to talk about SDOH data with some of these federally qualified healthcare centers throughout the state and being able to look at what types of data they're collecting, being able to look at what do they do with that data, or, in a perfect world, what would you do or what could you do if you had the resources and the means to do it. As well as also work that is being done statewide with a community health information exchange. And so that work starting with MMA and then moving over to the Maine Council on Aging, but also working with MEHAF and the Maine DHHS as well. So these are different types of partnerships and works that we have done. I think the really important piece to this that I do want to emphasize is that we do have these really great relationships with a lot of our participants that view our data or send us data to HealthInfoNet. But there are so many other folks too in the community that are doing this work that we really like working with, and some of those folks that will actually be presenting here in a few minutes as well to talk about their work with social health data too. But it's all encompassing lots of different folks throughout the state that really have the same drive and mission that we have. So when you think about what does a community health information exchange framework and components look like? We've learned a lot from these projects so far, and some of these different efforts. I think looking back on that last slide, some of the previous work that we had done, definitely some lessons learned, which really brought us to where we are today and the convening that we want to do today. And so obviously being able to look at all these different components that make up this pyramid, all of these in my mind are very important components of this work and things that you have to consider when you think about engagement, data standards, data governance, how to incorporate things into a longitudinal health record, integration systems and design, which ultimately brings us really up to that very top, which is the community care planning. So being able to take all of these different elements for that common goal and that common mission, which is that community care planning, and ultimately improving the quality of patient care that folks are getting throughout the state. So some key terms, sort of disentangling the social determinants of health. Name, certainly I think it is definitely the catchphrase of the moment, which is really exciting and great, but what does it mean? So really breaking it down into some different areas here. So looking at the structural determinants, so that sort of macro level causes of the causes, what's impacting society's health status. I think there's a lot that can go into that. Obviously, labor market here is the example that we used, but that's something that we kind of have to think about. There's social determinants, so the middle there, that meso level of what causes poor health that's impacting our communities. Employment desert, another example here to build off the labor market example. So that's obviously making an impact here in health. And then we sort of get down to that micro level, right? So what are the social risk factors? What are the social risk factor screening tools? So in my mind, they are separate things, but they also go hand in hand, obviously, but looking at the effects of the causes. So what's impacting an individual's adverse health status? And it could be unemployment, right? So having those different components really build off of each other. And so when you're thinking about how do you identify those social risk factors? There's got to be tools in order to do that. And some folks obviously on the call today are very well aware of those different instruments and key tools there to be able to document, evaluate, and integrate some of that social risk factor information. But really, when you think about the different levels, each of these components are obviously impacting each other, which then ultimately impacts a person's health. So also thinking about that disentanglement, thinking about social determinants of health, how all of those pieces that I just mentioned sort of come together, right? And make up that little ball visual there. And really what comes on the other side of it is social health data. And so that information is really what we're looking at. So that's what's really driving this and why we've in moving away from sort of the social determinants of health and really focusing in on the social health data information side of things. So here, really leveraging that whole person care. So surfacing individual social risks of poor health, culturally inclusive demographic attributes really contribute to health disparities across cross-sector efforts. So looking at it from that society perspective, looking at those structural components, as I mentioned in the example, looking at unemployment and the labor workforce and how that trickles down. So looking at it from that macro level, being able to assess on the micro level, so the individual risk factors and conditions which ultimately impact the process improvement efforts. And then being able to leverage this health information services. So looking at the structural, looking at the social, and also looking at the social risks. So having it really provide that whole person care. So looking at it in its entirety. So that's really the opportunity here that we are looking at. So how do we choose a plan here to move forward with this? We've level set, we've looked at the different definitions, what can impact each other, but what is that sort of, last mile of the patient care strategy that we can use? So it's looking at how to activate leading edge participants to accelerate the change. So hence why we have some really great folks in the community that are doing really great work to share what they're doing, which is why we've brought everybody together for the convening, which we see as really creating a domino effect for health equity actions and change across all of the participants that join us on this, this convening. Being able to advance equitable care and whole person data sets to strengthen our care systems and break down silos, which we felt was also a really important piece of this work. I think everybody does this work, but they don't always have the opportunity to share what they're doing. So being able to share that and breaking down those silos. And then being able to facilitate some health equity innovation, really by learning from each other. So understanding what's happening throughout the state, what's going on, different ways that we can share this information, possibly, being able to educate folks on some different applications and programs that are out there, but really being able to bring everybody together and share what they're doing. Why does this matter? So each of us require different types and amounts of services to improve our healthcare. So being able to know what's available is important. Being able to forecast, prepare, and proactively respond to this. So moving away from sort of a reactionary response and being able to proactively look at folks' emerging risks and needs, and then being able to improve that access and outcomes of care. So how do we really look at this from a proactive perspective, being able to share this community level information and opportunity. So wouldn't it be helpful to understand different patient populations, different demographic information that might put folks at a more vulnerable risk for certain social risk factors? Of those patient populations, are there patterns in medical conditions or risks that are contributing to their situation that could be mitigated if folks were really talking to each other? So bridging that gap between the traditional, medical care that's being received, but also bringing in some of the community providers to work with clinical folks. And then how can at-risk patients receive greater quality of care that's safer and more timely and efficient? So one example of this that I'll just run through really quickly is sort of determining a person's social risk. So a primary care provider sees a patient, they see that they're at risk for food insecurity. That primary care provider can use a centralized resource directory, being able to refer a patient to a local area agency on aging that operates a Meals on Wheels program. Because this person that gets referred for the service is a high-risk medical condition, that area agency on aging can sign up in HealthInfoNet for a real-time notification to know when an individual is not at home to be able to receive that meal because they've either gone to the emergency department or been admitted to the hospital. And so that area agency on aging is able to prevent food waste, be able to ensure that a meal gets to another individual who may need it the most. But it's also helping folks not waste time. So that staff person doesn't need to be driving more. They can actually change their schedule, be able to accommodate the fact that they don't need to go out and bring that meal to that individual. Plus that person stays on the area agency on aging's stays on their radar. So once they know that the individual has returned home, also a notification that they can receive, they can initiate services. So there's really no gap in care. So just an example of having that primary care work together with that community organization and being able to utilize the data that we have at HealthInfoNet to do that. So ahead of myself here, sorry about that. We have asked some state and national stakeholders who are invested in increasing information sharing and also see social health data as an important area. So we have brought in some key presenters to help us kick off this, this convening effort here to talk a little bit about how this is going to impact the work that they are currently doing. And to really bring us together, in my mind, as a big community. So without further ado, I'm going to introduce Jess Maurer, the Executive Director on the Maine Council of Aging, and Sarah Taylor, a consultant with the Maine Council on Aging, who are going to be our first kickoff presenters here.
So, am I on? Can people hear me? Yes. Okay. Thank you. I'm Sarah Taylor. I am a consultant with System Safety Group, and I am the program coordinator, one of two, for phase 2 of the Maine Community Information Exchange, or CIE. You'll hear me referring to it. This journey started back in 2020, where a group of diverse stakeholders came together to really educate themselves around community information exchange, what that means, is it something that would be helpful in Maine, and determined that yes, in fact, it would be. They did surveys, and as I said, there were many stakeholders involved. So that was phase 1. And phase 2 started in May of 2022, and I'm going to talk a little bit more about that. Next slide, please.
Hey, Sarah, do you know your video's off?
No, I didn't know my video was off. Sorry about that.
No worries.
There, you can see me. So what is a CIE, right? So it connects the social and health services through an integrated technology platform, coordinates care, shares information electronically to improve the health and well-being of individuals. It's similar to an HIE in that it is an ecosystem comprised of network partners, that's healthcare providers and community-based organizations or CBOs. We have a shared language, integrated technology platform, and share information to inform person-centered care coordination. And person-centered is really important. That's where we are. That's one of our values. Next slide, please. So the goal of the CIA coming out of phase one really is simple. It's better health through improved information, referral, and coordination. So to accomplish this, there are some different aspects. One is to collect health-related social risks information, compile that individually and in the aggregate, meaningfully refer individuals seeking assistance to providers. So closed loop referrals, that's what this is referring to analyze the results and take actions to improve care coordination, and to make the best use of resources within health and social services organizations, and then to identify unmet needs in communities, increase health equity throughout the state. Next slide, please. So this was the phase two governance structure. A steering committee was formed, and the steering committee members were part of that original stakeholder group. They guide the progress of the CIE work, and they oversee the work groups. We have 3 work groups. We have legal and policy. It's public policy. So that's really looking at all of those legal aspects related to the information exchange. We have a governance work group, talks about how is this going to be structured? How is it going to be governed? And data and technology, which is around software and technical infrastructure, as well as data governance. Next slide, please. So phase 2 activities, what have we been doing? A steering committee was formed, as I mentioned. It's made up of the members of some members of the phase 1 work group, and it's tasked with overseeing the work groups. And I mentioned those. The work groups develop charters with specific deliverables for phase 2 of the CIE project. And the data and technology work group has developed a business requirements document that has prioritized the longitudinal health record. It identifies key technical components of this information repository and provides use case statements for each of the prioritized technical components. Next slide, please. So I find this very helpful as a non-techie to look at this graphic to see what does it look like? What's a longitudinal health record? And as you can see on the healthcare provider side, we have EHR systems and all of the components and elements that Nicole had talked about. Then you have on the CBO side, the client databases. And, we have CBOs who are larger and have fairly sophisticated technology. And we have small CBOs that may keep information in hard copy, may keep it in an Excel spreadsheet, right? So information from providers goes into this data warehouse. You get the longitudinal health record. This is where you get analytics and reporting and notifications, which is another aspect of the CIE. Next slide, please. So next steps, we will be convening a community advisory committee. This will include people with lived experiences, advocacy groups, and representatives from underserved populations. They will help inform the work of the work groups and the steering committee. And we want to integrate community members in all levels of governance of this organization and this project. And we will also be convening a network provider advisory committee, and that will include both healthcare providers and CBOs. And we will define the phase 3 activities and priorities. This isn't something that gets done overnight. San Diego 211 is probably the best known CIE. I think they've been working at this for 10 years. So we aren't expecting an immediate CIE, but it is very, very meaningful work that we are engaged in, and will help the population of the state of Maine. And that's it.
Awesome. Thank you so much, Sarah and Jess. We really appreciate it. Going to
Can I offer just a couple of pieces. One, I just wanted to emphasize the idea that there is no one technology that will be used. That's a question that comes up a lot. That we have committed to honoring all previous investments that have been made, and also really ensuring that the voice of people will be included. We think this is another, and I love that you used a workforce solution, but that it's going to be a long-term part of a workforce solution over time as well. So just wanted to kind of bring those pieces up.
Yeah, absolutely. Great. Thank you, Jess. Thank you, Sarah. And next, we're going to be hearing from Lisa Talbert, who's the Chief Program Officer at Maine Primary Care Association.
Hi, can you hear me?
Yes. Hi, Lisa.
Hi, Nicole. Thanks so much for your presentation. I don't have slides. I just want to say a few words about our organization and what we've been doing along these lines. And primarily, I want the community health centers that we represent to speak to their individual experience. And I know you'll hear quite a bit from them over the next weeks. So the Maine Primary Care Association is a nonprofit membership organization, and we represent the collective voices of Maine's 20 community health centers through training, technical assistance, and advocacy. We're also called federally qualified health centers, the community health centers, FQHCs, that you mentioned earlier, Nicole. So Maine's CHCs provide high quality primary and preventive medical, behavioral, and dental health services for 1 in 6 Maine people at nearly 70 service sites. And so that's more than 200,000 patients receiving care last year from these health centers. The Primary Care Association has a number of coordinated multi-year projects with large numbers of health centers involved. And so in 2017, we launched the first Primary Care Association-led and CHC-focused patient safety organization in the country with 14 health centers involved. We also operate a health center controlled network, HCCN, the Community Health Center Network of Maine, which has 16 participating community health centers. And a great deal of the work that we're discussing today revolves around that group and a number of social health data objectives that project is working on this year and for the next 5 years. Maine MPCA also runs the Maine Workforce Innovation Network, which creates pipelines for recruitment and retention of clinical staff, including community health workers, and 12 health centers are involved in that work. I want to make sure to mention community health workers, or CHWs, and say that during the last year, many health centers have engaged community health workers to help them in the screening of social risk factors and the delivery of care to patients in relation to social risk factors. So what I'd like to say is that assessing, addressing, and tracking patient social drivers of health is now really central to health center operations across the state, and a really essential component of the programs that I just described. So engaging in this statewide coordination and the peer sharing that we have through this network is essential. And of course, electronic health records are all different across health centers, and indeed screening mechanisms for social determinants of health really differ across health centers. And so for us, this is among the most important work that we're doing right now. I'm less a data person personally than I am an operations person. And what I've seen is that the devil is often in the details in terms of how we screen, when we screen. Is it during a visit? Is it before a visit? Is it after a visit? And are we able to use that data to address social risk factors during a visit? Or do we wait until a patient leaves? And so and so that's really what we're very focused on right now, and quite focused on how community health workers help us with this work, whether they're employed directly by health centers, which is increasingly the case, or whether there's a contract with an external agency that works with community health workers. So I'm biased because I used to run a health center that had a lot of community health worker support, but this seems to be a trend that is extremely popular and working really well for health centers. So I'll let them speak. I'll let them speak about that as the weeks go on, and I'll close with that.
Excellent. Thank you, Lisa. That was really great. And a lot of what you talk about is a lot of what we are here to hoping to get out of the convening, and for folks to be able to share, because you're absolutely right. Not everybody does it the same. And so, yeah, I think it's really just learning from each other is really important. So thank you, Lisa. I really appreciate it.
I just want to point out a comment from my colleague, Susan Whitaker, who says community health workers may assist with screening patients for SDOH. And CHWs may assign ICD-10 diagnosis codes for identified SDOH to begin the referral and tracking process. And then I'll stop.
Yeah, no, thank you. Thanks for sharing that. That's awesome. All right, and moving right along, next we have David Wilson, or David Winslow, I'm sorry, David, who is the Vice President of Financial Policy at Maine Hospital Association.
Thanks, Nicole. Good afternoon, everybody. I just wanted to let people know that the Maine Hospital Association works with all 36 hospitals in the state of Maine. So they're all members of ours, and they all, as was pointed out earlier, also participate in HealthInfoNet. Similar to the Primary Care Association, however, a lot of the commonality when it comes to medical records sort of ends there. And that's, I think, always created a little bit of an issue, but I think as we're going forward with a project such as this, that needs to be really looked at and taken advantage of, because what we're seeing is that the questions that everybody asks are different. So that each of the hospitals ask different questions, understandably. And the questions that we might ask people about social determinants of health are, I know, different than the Primary Care Association asks. And then you get into even further, you have the HealthInfoNet that's working on this project. We have the Maine Health Data Organization that has a similar type of project going on. So I think the reason that all of these efforts are moving forward is because of all the potential benefit that comes from that. I guess what my plea to people here today, or my recommendation here today, is that the more consistent that we can get the questions that we ask patients, the more consistent that we can get the data collection, the better it's going to be for everybody that's involved in collecting this information. And it's going to be put together in a way that can be used most effectively by all the parties across the board. So to the extent that we can do that, highly encourage that. I was going to use myself as an example. I've accessed healthcare a few times here in the last little bit at a hospital-based physician practice. And the amount of paperwork that I'm given, the amount of questions that I'm asked, it's just, I think we've all been through it. It can be really a little bit overwhelming, especially when people get older. So I think we need to kind of keep that all in mind as we go forward here. The other thing that we get is what I call question fatigue, which is that the more questions that you ask somebody, the less likely that they are to answer those questions. And that's one of the things that we deal with even now at this point in the process, which is that a lot of the questions that we ask for all the right reasons and all the reasons that we have been discussed here today, oftentimes they don't get answered, or they don't get answered accurately. And I think we need to keep an eye on that as well. So I think we need to figure out a way to make it as consistent as possible across the board. And I also think that we need to keep in mind that the questions cannot be unlimited that we ask patients as we go forward. So I think all of those values sort of need to work together as we go forward, in these efforts, which are obviously very, very important, which is why everybody's, been involved in it from their point of view from the beginning. So I think I'm going to stop there and, hopefully answer questions at the end.
Yeah, excellent. That's great, David. All really good points. Definitely agree with you on the paperwork fatigue piece. But yeah, kind of figuring out a way, right, to come together, take the burden off providers, take the burden off patients, and really help to streamline the process. So thank you for joining us and for representing Maine Hospital Association. Next, we have Jessica Reed, who is the Clinical Quality Manager at Maine Medical Association.
Hello, everyone. It's great to be here today. We have just a few slides. Again, we are the Maine Medical Association Center for Quality Improvement. And thank you, Nicole. She mentioned my name is Jessica Reed. I'm the Clinical Quality Manager for the Maine Medical Association Center for Quality Improvement. And big thank you. Thank you so much to HealthInfoNet and Chad and Nicole for this opportunity to talk with you all a little bit about how our organization intersects with all of this work that we're doing. So thank you so much. So our mission and our organization is to improve health by supporting clinicians in their efforts to transform healthcare and by building clinical and community connections. And when we say clinicians, we think of clinician teams, support staff, every person that patient touches when they walk in the door until they leave. So already you can see where this work directly impacts the majority of what we do. Next slide, please. So who we are. So some of you may not know who we are. So we are a neutral convener. We are, again, like I mentioned, committed to transforming health and healthcare in Maine. And we have multiple statewide innovative, and we focus very much on quality improvement initiatives, and we span this continuum of care. So for us, this social health data and things that we're talking about really, right from prenatal to older adult initiatives, weave into this work every day. So next one. I'm going to talk a little bit about our work, and I'm not going to go through per se, next slide, all of these, but we just think it might be helpful for y'all to see some of the programs that we work with. And I think as you look down through these, as I'm talking, you will immediately see where this work intersects here directly just by the nature of these projects that we work on. So this is where we have multiple programs looking at opioid safe prescribing and the treatment of opioid use disorder. Next slide. We also have another bucket of work in where we look at maternal, perinatal, and child health improvement. And again, you can see multiple initiatives and programs, grants that we work on and run. And then we have prevention and some of other, and again, just even hearing some of our colleagues, you'll notice that we have projects with them. And so it's really exciting for us, for this group to get together and really, build this work as we move forward. We look forward to seeing how, what people are doing out in this space, just in the short time that, we've all been convening together and really talking about these. We know that we've been talking about these things for years. So I think it's really exciting to really just even have today, right, happen and convene us all. So next slide. So again, just by looking at those projects, you can see the intersection that we have, obviously, with social health data and all that we do and working clinicians. And obviously, we're all here today. I think when we look at this from the largest visual perspective is to improve the quality of care for the patients and communities that we serve. And so I've had the pleasure, we also, as our organization, have this historical background. So we've worked with many stakeholders that are here with us today. We're fortunate to work on the Maine Community Information Exchange that Sarah and Jess Maurer are now holding and so nicely just talked about a moment ago, being on that planning committee and working closely with Charles Dwyer and me to move that work along. So it's in phase 1. So it's really exciting as we learn about phase 2. And then also another initiative back 2019, 2020, again, working with Jess Maurer and Ted Rooney, looking at a healthy aging population initiative, HAPPY for short. And so again, that was focusing more on older adults, but again, social determinants of health was weaved into that conversation and how we look at that to address gaps in care, because we know we have to look at that whole person to really treat them with the highest quality of care possible. We, again, looking at the ones that we just showed, those programs, you'll see that all of them, every single one, intersect with at least one risk domain of social health data. And again, we have multiple projects that we work on every day with practice teams to improve clinical workflows. And again, identifying these social risk factors and looking at that impact on everyday health, and how do we do that, and what's the best way to do that moving forward. So again, we embrace this work. We've been part of this a very long time. I think these conversations, these conversations started back with Maine Quality Counts, and then into Qualidime, and then into the organization that we are now as the Maine Medical Center for Quality Improvement. So thank you for this opportunity to talk about this. And here's my contact information if you have any questions about anything that we do. Again, very happy to talk to anybody more about it. So thank you so much, Nicole.
Excellent. Thank you so much, Jessica. I appreciate your time. It's really great. And last but not least, we have Julie Rizzo, who is the Senior Director for Network Engagement for Civitas.
All right. Hi, everyone. It's a pleasure to be joining you today. And just a little bit about me. So I live here in Maine. I'm in Falmouth. And I went to the University of Maine at Farmington for community health education. I have a master's in public health. And then I also worked for Martins Point Healthcare for about 5 years before I transitioned to work for a national network. So HealthInfoNet is a member of Civitas Networks for Health. We are a national nonprofit membership association, and we represent the majority of health information exchanges in the country. So really our goal as a membership organization, again, that are largely leading health information exchanges and regional health improvement collaboratives. Those entities are also doing, highly collaborative multi-stakeholder work, looking to improve quality, affordability, and other major sort of hot topics and important issues in health and healthcare reform. So we find ways to convene our members for exchange of best practices, networking, and increase connections across the national network. So I've already talked a little bit about who our members are. I'm trying to keep this quick because I know we're running short on time. But one of the things that we do at Civitas and have a sort of a tremendous opportunity to do is to look across the national landscape. So hearing today about what's happening here in Maine, it's very much in line with what we're seeing across the country. We host a social determinants of health and interoperability work group for our members, and we have representatives from the majority of our membership that participate in that work group. And at the beginning of 2022, we decided that we wanted to do an in-depth survey of our members' work and the work that they're doing to address social determinants of health. And that can be both within sort of the technical aspects of the data exchange itself and interoperability, or more within community, thinking about building out capacity and applying technical assistance and supporting community-based organizations and social service providers to really be able to get to a place where you have closed loop referrals and this bidirectional exchange of information to support true whole person care. So this first year was, again, developing the survey itself, which we call the profile, and then pulling together a compendium. We had 36 submissions, and really, again, with the goal of being able to better articulate what our members were doing across the country. Civitas members are known as being very action-oriented. They're regarded as implementers. And I will just note that, as you all are experiencing and feeling, this work is evolving quickly, but there is a very apparent need to be able to sort of meet the demands and make sure, again, that we're able to do better for patients and those that need or have social needs that need to be addressed. So the goal of the profile was really around trying to have more sort of qualitative opportunities to better understand what people are doing, what organizations are doing across the country. But as a result, we actually were able to pull some quantitative highlights, and I think it gives a nice snapshot as to what's happening across the national landscape. So I'll share a few of these highlights with you. So we asked a question about sort of what is the stage of work that they're in. And so, as you can see across the membership, and again, these are health information exchanges, regional health improvement collaboratives, quality improvement organizations, all payer claims databases. that, there's quite a spread, and it's, ranging between formative discussions, stakeholder engagement, early planning, business plan development, implementation planning, operating, and then expanding and adding. So we can move on. We also asked about what are the social needs being addressed in this work. And really, as no surprise, food and food insecurity rose to the top, and then, quickly followed by housing and transportation insecurity. So another important question was just around sort of the structure and the governance of having sort of social determinants of health data, and also being able to address various efforts within community. And so, this is all of our members in our full category have to be governed by multi-stakeholder boards. Some of the work is happening at that formal board level. There are steering committees, work groups, advisory councils, and other ways in which people are convening. And so we also think it's really critically important to include those with lived experience in this work. And as you can see here, many are doing that through surveys and focus groups. Some have advisory committees, others are members of work groups, members of steering or leadership committees, and or participating in the actual governance itself. So that was a really quick run through, but I think wanted to just convey that, the work that's happening here in Maine is consistent with what is happening across the country. And I think we, feel really strongly at Civitas that, it is so important that it's highly collaborative, that, whoever is stepping in, like in this instance, HealthInfoNet, is really able to act as a trusted, neutral convener, working again to be highly inclusive and continuing to sort of expand on the diversity of perspectives that you're inviting to the table. And based on what I heard today, it sounds like you're moving in the right direction and taking a really thoughtful approach to the work. And I know that's important for those of us who reside here in Maine. So thank you. And if anyone has interest in learning more about this work or following up, please don't hesitate to reach out.
Great. Thank you, Jolie. Really appreciate it. Lots of great information. And I think getting that sort of national perspective too is really helpful. And so thank you to all of our presenters. We thought it was really important to bring everyone together, to highlight them, to talk about them, for them to talk about their work, and for how it's going to be intersecting with the work that we're doing with these convenings. So thank you to everyone who gave their time for that. I know we've got a minute left, so I'm going to talk really fast here. This is an overview of our different sessions that we're going to be having. And looking at our next session, which is our deep dive number 1, is going to happen on February 1st, which is looking at our social health data collection methods, and then so on. So I think Chad's providing some information into the chat on how to register for those sessions. To sort of wrap things up with a nice bow, like I said, we're very excited about this work and these convenings, and the folks that are taking their time to share with us what they're currently doing, some lessons learned, and just being able to share, I think, is really important, and building those connections that will hopefully ultimately really provide some really great quality care improvements to the folks that live here in our state. So thank you to everyone who joined our kickoff call here today. Obviously, I think there was some really great information and questions in the chat. Before folks jump off, I think there was a question about hospice information. I didn't want to forget about that before I closed. We do have some hospice data in the exchange. It's largely coming from those hospice organizations that are connected to our larger healthcare systems. but certainly I can follow up too with the individual who put that question in. But I didn't want to forget before we ended. So thank you to everybody that joined. We look forward to seeing folks in our deep dive sessions. And thank you so much. Have a great day.